Good morning, everybody. Thank you for joining us this early following a great day yesterday where we almost touched every single aspects of mitral valve repair mainly. And we're going to continue this morning with what we think is a very interesting masterclass in mitral valve replacement this time. And I have two incredible panelists, world famous in the world of mitral valve surgery that are going to share their knowledge. So let's start with Marc Gillinov, that obviously needs no introductions. Marc.
Thanks. It's great to be up here with David and Denis. Yesterday we talked quite a bit about mitral valve repair, and mitral valve repair is wonderful. It is exactly what we want to do for people with prolapse. But if you go by the exhibitors, you'll see that there are mitral valve replacement prostheses, and we use these from time to time. They save lives, they extend lives, and there are reasons to replace the valve. So not all valves can or should be repaired. I've had patients who have received a replacement act like I gave them cancer. Oh my gosh, you gave me a replacement, I'm going to die. Not so. There are people who get replacement, and they do very well. And when I was thinking about different sorts of scenarios where a replacement is more likely than repair, these are some of them. Rheumatic valves that are mixed, severe ischemic MR, severe MAC, degenerated bioprosthesis, of course, certain failed repairs, some people with endocarditis. And then Denis reminded me as we were talking of a growing area of mitral valve replacement, failed MitraClip. Many of those valves get replaced. So what do some of these cases look like? Here's a typical mixed rheumatic patient. She's 62, short of breath, exercises, but is not doing what she can or wants to do. She's got stenosis and regurgitation, and she knows she's going to get a replacement. She does not want Coumadin. And you see this is a valve. I mean, there are some people who might consider working on this and repairing it, but it's going to be an uncertain repair in terms of durability, typical fish mouth on 3D echo. And she did very well with a bioprosthetic mitral valve replacement, back to yoga, back to chasing her grandchildren around. Severe ischemic MR, we know that in most cases, a repair for severe ischemic MR, meaning just an undersized angioplasty, is an unreliable solution. Repair for ischemic MR, you can't count on it. We don't know enough yet to know in whom does repair last. So here's such a case, a 66-year-old guy who's had a previous CABG and an AVR, so he's a third-time redo. He's short of breath, he's tired, and he's got his aortic prosthesis, his native coronary circulation, not much going on, and he's basically living off his lima, and he's got some restriction of the leaflets. He's got a lot of MR. He's already got one bioprosthesis in place. Your most certain operation for someone like this who is relatively high risk is going to be to replace that valve. And even with replacement in a relatively uneventful quick operation, he was in the ICU, he had a balloon, took him 11 days to get out of the hospital. It would be really terrible to have a failed repair in such an individual. So he did just fine after almost 2 weeks in the hospital with that valve. We heard yesterday a fair bit about severe MAC. This is a real problem, not to be underestimated. And when you're operating on somebody with severe MAC, the first question you've got to ask is, should I operate? Because oftentimes their valve issue is not a life-threatening issue, it's threatening their lifestyle, but the surgery can be life-threatening. So I want this 75-year-old grandmother, if she's going to have surgery, I want her to tell me, I cannot live like this. This is so unacceptable, I cannot live like this. Then I'll consider operating on you. And she had mixed disease, coronaries were clean, but this is what we've been seeing a lot, and this is big MAC. This is not just a little bit of P2 flail with a bit of MAC. This is a valve that is going to get replaced, and very easy decision-making, replace that valve. And in this case, she did wind up with a patch, which David and I were talking with Joe and others last night, both Joes, Joe Wu, Joe Chikwe, I mean, this is a really, really big operation. This is not to be underestimated. This is a big day at the office to do this operation. And what you want at the end is a patient who has survived and has a functioning valve, no matter how you do it. And then some previous repairs you just can't fix. Here's somebody who had a previous repair. Her valve became somewhat calcified, and I thought going in I'd have a reasonably good chance of re-repairing this valve because there is fairly good pliable leaflet motion, but when I got in there, the leaflets were calcified, calcium extending into the annulus, some areas of restriction, some of prolapse, and I thought I want a certain result. And finally, another scenario, really bad endocarditis. I mean, of course, we'd like to repair these valves. We heard a wonderful talk on endocarditis yesterday, but at times when you've got a valve that is just destroyed, you might be better off by looking at that and replacing it. So that's the group, including a failed mitral clip, who gets a replacement in our hands. Which replacement do we use? This is what's been going on at the Cleveland Clinic in the last 25 years. We used to use a fair bit of bovine valves in blue, and we've moved to the porcine in red. And if you look at just the raw numbers, porcine again in red, this has been our preferred valve for about 15 years or so. And now the iteration of the valve is the Epic Plus. And what do we like about this valve? Well, what I like about it is it's really easy on the surgeon, me. It makes my day nicer and it fits well in the patient. This sewing ring is really, really compliant. I tell the residents it's luxurious. You know, it's like sitting down in a chair that it just feels good. And when the needle passes through there, I mean, you'll know what I mean. It just feels really good. And I love that the struts are very short. I mean, basically, you can't mess this up. Even if you put a strut in the outflow tract, which you don't want to do, but even if you did, it's not going to cause any significant obstruction, and the struts are rounded, they're not sharp, they're just, it's nice. It's a luxurious valve for us, and it's designed in that way. It is radiopaque, which you see in the upper left, meaning easy to put a valve in valve. Its holder is pretty easy to use, and then at the very bottom left, it's got a little suture that goes around each strut so you can't loop a strut, which would cause you'd have to redo the implant. So that's one feature. Another feature is it's like every valve has a special treatment of the tissue to prevent calcification, which has resulted in very, very nice durability for the valve. Unlike other porcine valves, it does not include the muscle bar of the aortic valve, so that gives you a better opening, better hemodynamics to the left versus on the right where there's the muscle bar. And the gradients are good. The labeled size is actually the actual size. You know, I know now that the FDA is requiring that valve manufacturers label what the valve size is, not just make up some numbers. But these labeled sizes, which correspond to the tissue annulus diameter, give you a very acceptable gradient, you know, gradients of 4 and 5. And it is especially useful and easy if you're using a small incision where there you have a very small skin incision with a sternotomy, partial sternotomy, right thoracotomy, robotic, any or all of the above. It fits nicely in your small incision and it's somewhat flexible or compliant. Of course, the question always is with any bioprosthesis, does it last? Is it durable? And these will all wear out over time, but this one is very durable. It sits very well with any other bioprosthetic valve. And here's just the largest study of 14,000 Medicare patients. These are the sizes implanted to the right, and as you'd expect, 27, 29, 31, all sort of normal valve sizes. And at 10 years, the freedom from valve reintervention is 91%, which is pretty good in a Medicare population. So that is in line with everything we see, meaning this is a trustworthy valve. You can definitely trust it. And if you look at the data from several other studies, it's all in the A range, you know, 90, 95, 96%, 10-year durability, freedom from SVD. So the valve does last, and as it lasts, it maintains its hemodynamics, the EOA and the gradients stay stable. So it checks that box, which is what the patient always wants to know. We want to know, is this valve going to last you? And the answer is, yes, it will. But what if you get it when you're 65 and it wears out when you're 77? It is well designed for a valve-in-valve. The biggest bars, the sort of medium blue, are valve-in-valve interventions in the mitral position, and they are going up. And it is debatable what's better, a reoperation or this. Patients prefer this. Will these be durable? We'll have to see. But the fact is these operations or procedures are occurring, and one of the biggest issues with the planning is you need to avoid left ventricular outflow tract obstruction when you put a valve-in-valve in the mitral position. What causes that? A high-profile bioprosthetic valve with a certain leaflet configuration. And this valve, because it has very short struts and because of the way the leaflets open, does not cause left ventricular outflow tract obstruction. It's also easy on the cardiologists, and it's nice to do them a favor and make something easy. It's easy because fluoroscopy shows their radiopaque markers. And one thing it does not do is it doesn't curtain, meaning the leaflets don't get in the way of the outflow tract. And the valve on the far right, you see the leaflets spread sort of like a curtain. Valve on the far left is the epic valve with a sort of valve-in-valve simulated. The leaflets aren't curtaining. And here's just sort of what that looks like. On the right is the leaflet curtaining, which would be obstructive. On the left, it's not. So hemodynamically, that's a very good feature. And let me do just two more slides. 3-year data on valve-in-valve, which is kind of meaningless, but at 3 years seems to work. What we want to know is at 10 years, does it work? And then my final slide really is just why do we use this valve at the Cleveland Clinic? Why do I like this valve? And these are the reasons. Again, this luxurious sewing ring, it's just compliant, needle feels nice going through, it's easy to implant, and it helps you if you've got sort of a hostile annulus. It really sits well. Short struts, meaning you can't mess it up. Low risk of left ventricular outflow tract obstruction. Durability looks really nice. I can talk to the patient and say, this valve's going to get you 10 years in almost everyone. And should you need a valve-in-valve, you're well set up for it. So that's why if this week, if I have to replace a valve, this is where I'll go. Thank you.
Thank you very much, Mark. Now let's continue with Dr. David Adams, the co-directors of this great symposium, and as well, world expert in mitral valve surgery. Dr. Adams.
I just wanted to let everybody know that I wanted to first start by thanking Abbott Life Sciences for helping us have this breakfast, because as you noticed yesterday, it's the only time we get to talk about mitral valve replacement. And I think, Mark, your points were so salient, and particularly this sort of idea of a modern prosthesis. Yeah, all of us that grew up in the Magna Ease days and things like that with sharp struts that were longer realized that the implantability of a prosthesis is the most important thing, because everything else we can argue about, is it one size bigger or smaller, or is it does it last 10 years or 12 years? But you got to survive the day of surgery with a good result to get to all the rest of this stuff, and that's why I think these modern prostheses really do matter. And I thought that since we never show these, but we are going to in December in the Electro Conclave, we should probably actually have a session about it and also talk about not only the data and our logic behind using bioprosthetic valves, and then in the discussion we'll have a couple of minutes to talk about choosing bioprosthetic valves versus mechanical valves. But the first thing we got to do is we got to get the valve in safely. And I was going to show you a couple of these cases, 4 of them to be exact, of just simple ideas around valve replacement for the younger group in this audience that hasn't done a lot of it yet, because these guys make it look so easy. But there are tricks, and we never share them or talk about them, but we should. So let me show you a couple of these examples. Here's a 70-year-old patient. She's sort of sold as having rheumatic disease. She's got fibrotic disease. She's having a mixed lesion. So by definition, at 70, this is where you are automatically defaulting to, I hope, to bioprosthetic valves. Occasionally, you'll be surprised inside and find something that is simple to repair. I know Jabreen would repair all of them, but we don't. In this setting, we probably would go for replacement. And here's an example now of a valve that you just look at and you know you're going to do a valve replacement. orifice not that big, very frozen valve, frozen commissure. I'd give it a try in a 40-year-old, not in a 70-year-old. At 70, this valve needs to come out. And this is an interesting valve because you can see this idea of, we're going to preserve the posterior leaflet. It's not so easy when your commissure is calcified and frozen. So you've got to be a little bit thoughtful about what you're going to save. You see that trick right there? All you junior guys, you cut the anterior leaflet and you use it as your holder to come around the posterior commissure. It's going to be a backhand. You'll watch in a different video, you bend the needle to create a hook. And at this point, around 4 o'clock, around 2:30, you're going to get to, or 2, you're going to get to, you have to transition from backhand to a hook forehand. That's when you want to bend the needle like a V to hook up underneath it. Once you get this corner done, the rest of it's going to become very straightforward. But especially if you're doing valve replacement for the right reasons, small calcified valves, fibrotic ventricles, thick atria, that you really want to know that trick. Once you've got that in, then it gets to be more straightforward. Look at the thickness of the papillary muscles. They're glued to the valve. That's typical in rheumatic disease. So it's always a decision, what am I going to leave behind and what am I going to take out? Invariably, you'll find calcium. So I could say I just abreaded Mac. That's not really true. This is just part of the process of rheumatic disease. But you can see that methodically you're going to go around and you're going to get into the commissural area, and invariably in rheumatic disease, you're going to end up taking out the posterior leaflet. Now, you hope you're going to really implant something. You're going to keep some annular papillary continuity, but it is not like when you do other valves. There always is going to be parts of the posterior leaflet invariably that need to come out because it's all part of the same calcific mass. And there you can see it's not just take your scissors, whack it out, and start putting your hand out like Denton Cooley to throw the sutures in. It's a much slower, thoughtful process to do this safely because, as Mark said, you can hurt people doing this operation too. This is something that's, you want to take your time and really think about. There you can see we took out the margin of that posterior leaflet. We preserved the secondary cords, and then we can put our sutures in, and that's the next step we'll talk about a little bit in a minute. But there you can see, honestly, in these small valves, it's going to be a small prosthesis. As we talked about yesterday, don't worry if you can't get your incisor through the valve. These valves are basically designed to be able to be implanted supraannular. You can do that if you need to. So you can really have the struts are everted, implant it oversized, and then the struts will open up. But the key, if you're going to do that, and that's why we did it in this case, if you're going to have that kind of tight space, then you've got to take out more leaflet because you don't want the leaflets engaged with you don't want the old leaflets engaged with the prosthesis. So that's what we're always doing because we know those struts are going to come out a little bit more. We're just going to continue the journey. Each one of these things has, anytime you watch a valve replacement, you'll see something that's worth talking about for a second. Here's a 70-year-old, it's got mixed disease. Here's the echo. Again, you get this feeling that she's got fibrosis and calcification in the sort of P1, P2 area. Always look at these mixed lesions and be very thoughtful. When you have mixed lesions, if you have some inflow and some outflow, that gets to be a little bit more interesting. And here again, you can just see the restricted leaflet motion. There, look at the papillary muscle. It's glued into the anterior leaflet. So once you start getting in that scenario, you're going to do a replacement. It's almost like a congenital anomaly there. It's not common to have it that high up in the annulus. But the same thing, you're going to use the anterior leaflet to put it in, or to put your sutures in. This is where it transitions to your forehand. And you'll take this out. It's fun to watch it real time. Here we have the calcium. We've saved part of the anterior leaflet to implant the valve above. You see all the calcium in the annulus. We'll implant the valve above the calcium in this part. And this is where it gets tight. If you have calcium in P1, then you've got the circumflex nearby if you're trying to bounce behind it. So oftentimes we'll try and reinforce that, have a double layer of leaflet. And you can see now I don't have to go back 4 more millimeters behind this sort of inflammatory mass. And so we commonly do that. I always say chicken heart surgeon. This will not cause problems. And invariably, when you've got this thickness, you can really create an annulus, sort of a neo-annulus, without getting behind calcium bars, which I really like to do, having made every mistake on the planet in this space. You saw we cut the cord, some of them to let it fall back, very tiny valve this time. And it's that same idea of dropping the valve in and then taking the string out. The rest of it's straightforward. Those little attachment clips, there's the anterior leaflet, there's Mark's the outflow tract side. See, we're doing an AVR. So you can see you have a wide open outflow tract. And as Mark said, even if that strut is cheating one way or the other, it can't make a difference when the outflow tract is open. So that's another reason if you're not using modern bioprosthesis, you have to get one, because you will protect more patients. But that shows beautifully how the outflow tract isn't compromised. And there again, you can see the sort of normal flow of someone like this. Now, the next one's a 90-year-old. He's got endocarditis and atrial fibrillation. Obviously going to be a replacement, unless you, again, never say never, because sometimes if the annulus is involved, it's safer to do repair. But here's the valve. Massive leak. You can look at the, for the junior people out there, if you look at without the color on, you learn everything. It has to be a perforation because the leaflets obviously have good motion or coming together. There's not a prolapse. So every single time you look at echoes, your first 5 years in practice, make sure you understand dysfunction. And to do that, you have to get people to turn the color off, because when you come in the room, every anesthesia resident will only have the color on. You can't be a good mitral surgeon if you don't turn the color off. There's the valve, infected, perforation, 90 years old, not for discussion, easily patched in a young person. Again, in this case, we did a little differently. We detached the posterior leaflet, and now we're using it to reinforce underneath. So it was a short posterior leaflet, not calcified. We detached it and then used it as a buttress with this pledget underneath the annulus, which I like. In this setting, you don't know how good the tissue is going to be. And then the same scenario, use the anterior leaflet as your holder. And that little nerve root's very helpful when the atrium is overriding. And this is this transition bite. Invariably, one side will be backhand, one side will be forehand. That's bending the needle to create that V. So you take the needle at the end and you bend it. It's really useful to create like a V, so it's perpendicular. So I drop my hand in, now I can just lift straight up like a fish hook. If you're trying to make turns in very small holes with very thick atria, you can't make the turn without getting too far wide. And of course, remember for your boards, that's where you can still get the AV node. You can create heart block with that stitch if you're not careful. And the younger the child is, the easier it is to do, or the younger the patient, including valve repair, you can get it. So you really do want to stay close there. So now you see how we're bending those needles to be able to hook up. Then the rest of it becomes straightforward again. You've buttressed the posterior leaflet. You've done the hard side of the anterior leaflet. None of it's hard. It's the side that takes a little more attention. And again, just work your way around it, keeping the leaflet there until you're really ready to take it out, because it is a great holder. And then you have perfect exposure to take out whatever you want. You can see we're able, almost always we can preserve both the anterior and posterior papillary muscle continuity, which is our goal. But not a lot of leaflet tissue to grab into the prosthesis. Continuity, but not leaflet tissue. And again, it's nice when they snugly fit like that. Sometimes they won't. Usually we'll upsize, particularly in younger people or if they're large people, and just let it override a little bit. As Mark said, I love what you said, Mark. What did you say? This is luxurious. It's also luxurious when you're in tight spaces in reoperations and the apex is frozen. We never take the apex down. And that's where it's really easy to see this because of the way the holder is designed. You have space in between the little bars that are holding the struts open, which is, all of it matters, believe me. If you're in a tight space, re-op, multi-re-op, heart-stuck, valve-rotated array, that's another reason you like this little cuff and this little sizer, because you can really see what you're doing in there. And then the last one is just one last example of the process. Here you'll see the calcification. You sort of see this bar of calcification, posterior leaflet's not moving. Interesting, torn leaflet, not uncommon if you have a calcified hinge point. Rock solid P1 that goes into the annular calcification. You've already known my instincts. We could take that out, so a pericardial patch in, then implant the valve in the patch. You'd have to do that if it was infected. In the non-infected setting, we're going to take it, be a chicken, we're going to take it out piecemeal. So we get the majority of it out. We're going to level it to the angular plane. And then we're going to find a way to reinforce this side. And sometimes we start down there just because we can't wait to get to it. The hardest, where the calcium is, just because your eyes are drawn to it. So it's fun to do that too. And there you can see we're bouncing off the calcium. It's like when you were in the old days when you put subclavian lines in, bouncing off the clavicle. You want to take a needle and try and bounce off of it if it's not too far back and you're on the side of a valve where you don't have structures you can hit. And here we're making sure we preserve something from the anterior papillary muscle. So we just have this little piece of leaflet. But it's this sort of, take your time, respect these replacements. You really can, they're really fun. They're nice, but you can really hurt somebody doing them. So we're really thoughtful about everything, including these replacements. And yeah, Marc, I think you'll agree. We'll talk about it in the discussion. If you're doing valve replacement for the right reason, they can be complicated. They're really not complicated if you do them for the wrong reason. Big valve, Barlow, giant hole, atrium's dilated. You do them in some of these little tiny Mac ladies that are 80 and have very hypertrophied atria from AFib. They can be, interesting. Ischemic patients that don't have LA dilatation, they can be interesting. But there again, you can sort of get the sense of the orifice you want to create. And one of the reasons I'm emphasizing that is because we've taken out our share of mitral valve replacements where the posterior leaflet has enveloped the strut and the adjacent leaflets, which is what's led to early failure. We've also had patients that have had LV outflow tract obstruction from the anterior leaflet, the entire anterior leaflet draping over the strut and just blocking the outflow tract. And so you do want to preserve continuity, but what you don't want to do is just leave every bit of a thick, big leaflet in the middle of the valve, because I think it hurts the prosthesis and can block the outflow tracts. And so that's obviously, again, going to be straightforward, the rest of it. And that's what I wanted to show you guys today, so we can have a discussion.
Excellent presentation, and again, great videos and technical tips for the younger surgeons. Waiting for questions from the audience. I'd like to ask you both, nowadays, how would you plan on the lifelong management of those patients that you need to replace the valve? And at what time would you stop using mechanical products? And would you plan for valve in the future? And would you, so what would be your age? Maybe, Marc, do you want to go first?
That's the question every patient wants to know, and they frame it in terms of the terms that we use. It's Coumadin versus reintervention, although some mechanical valves require reintervention. But anyway, what age? People who are in their 60s or older, I suggest to them, I'm in that age group, I would take a bioprosthetic valve, and I would be thinking I will either need a reoperation down the road or a valve-in-valve. I don't know how long the valve-in-valves are going to last. No one knows that yet. But in their 60s, I would say, here's what I would do. And in the 50 and younger, I would have probably taken a mechanical valve. And in the middle is tough. It all depends on the patient. But the 50 to 60-year-olds these days seem to want bioprostheses, especially when you ask them about repair. Everyone has to give, what is my second choice, just in case I'm the 1 in 100 you can't repair. And most people choose a bioprosthesis. Is that what you find?
I keep it very simple. I can't remember the algorithm. Everybody gets a bioprosthesis the first time. That's my bias. It's my bias because it's what I would always do for my own family. And the reason I say that is because I'm looking for the responders and non-responders. Just like if I have a LAD lesion and they can put a stent in, I'm getting a stent. Dream on about all that Lima nonsense. I'm getting a stent. And then if I come back in 2 years and they start talking about more stents and rotor-rooters, I'm going to go to Joe and I'm going to get my mammary put on my LAD. But the one time I'm going to get it, and the reason I'm going to do it is because of the shape of a bell curve. Remember, we talked about 10 years or 12 years, but you know, sometimes you put these valves in, they last 18 years. You never hear them, there's no blood thinner, you go skiing, you go, do free solo, do whatever you want. And then if you come back, don't worry. And now, Mark, you're going to agree with me on this. This is, I told you guys yesterday, this STS calculator, I don't believe it. I don't think it has anything to do with what we do in our hospital. I don't think it has anything to do with a lot of practices. I have no idea how they get these numbers. They pull them out of thin air. We tell patients in the modern era of replacement, if you come back with a good ventricle, your pulmonary pressures are reasonable, your kidneys work, it's the same risk as the first operation. Why wouldn't it be? The days of mysteries, you do CTs, you plan, you know where the ventricle and the aorta are. There are no surprises in reopening anymore. You can get the groin out if you need to. In the absolute tragedy of a case where it's really hostile, then you can go and talk about all the other things you can do, including go on the heart-lung machine, decompress the heart, open it again. I think that the data being used to create these numbers about reoperation risk is all in an era when we didn't CT patients before we did reoperations, when we didn't have senior people in the room. When we all trained, it was like, you're ready, you're the chief resident, go in there and get that mediastinum dug out. You're going to have a couple of mistakes, but it's okay. That's not the way we do it anymore. And I think that we really have to tell patients, which I tell them, that your lifetime management, you come to me and you're 40. Your lifetime management is this. You're going to blow out your 86th birthday candles if you otherwise take care of yourself, but you're not going to die of heart disease. And the reason you're not going to die from it is because every 10 to 20 years, you're going to find a center that does this stuff for real, and you're going to go to them and they're going to get you through it safely. And I absolutely believe that, and I will challenge anyone to tell me a staged reoperation of mitral valve surgery in centers that do this and know how to do it, that it's safer to take blood thinners for the same 30 years. I will absolutely challenge anyone on that. If you take a blood thinner for a mitral valve prosthesis, Joe Chickwee looked at it with our group in New York State. Remember the 1% per year admission for bleeding? Remember that one? And you can test your belly yourself or what, all that nonsense, give yourself a new disease for the next 20 years. If you go to the hospital in New York State, because remember, we have mandatory reporting, we have SPARCs. If you go to a hospital in New York State with bleeding for a mechanical valve, you know what your mortality rate was? It wasn't I cut my finger, I went to the ER, they put a Band-Aid on it. If you go to the hospital with bleeding, you had a mechanical valve, you had an 11% mortality rate. It's a real deal, 1% per year, and then if you end up in the bucket of 1%, it's a tragedy. It's much more risky than getting a valve replacement. So Mark, when I come to you, not only am I going to get a valve replacement, we'll move on because I don't want to dominate, but then we will also talk about planning my reoperation. Please put a little piece of Gore-Tex or pericardium here, because I'm not probably getting a valve-in-valve based on all the ones I've taken out and looking what the interaction is of leaflets with that prosthesis and how little they last. But I'm waiting for papers and data.
I've promised that we're going to be on time. We have one question here, Manny.
Thanks, Denis. Thank you both for those nice early morning talks. I just have a question, Dr. Gillinov. It was a pretty impressive shift over time at the Cleveland Clinic from bovine to porcine bioprostheses that you showed. Are those strictly based on clinical factors that you guys noticed over time looking at long-term results with that valve, or other financial, whatever things that came into play, or was it really sort of these valves aren't working as well, so we're making a shift?
It was implantability. The valve
Exactly.
is just so easy to implant. And I remember being with David once at a different company that had mitral valve with sharp struts. And you picked it up, and the engineer who designed it was there, and you said, this valve kills people.
That was before it was ever released. I said, this valve will create problems. You better be very thoughtful how you measure it and tell people to implant it.
David, would it change anything in your choice of bioprosthesis if the patient is already in atrial fibrillation, he has been taking warfarin for many years?
I mean, honestly, and again, I realize in this particular circumstance, I have a strong opinion. Most of the time, I'm very, relaxed, live and let live. But this time, I have a very strong opinion. And the reason I have a strong opinion about that is if I have a mechanical valve in my mitral position and I break my hip or I fall down those stairs, that's going to be kind of tricky. If I'm in AFib and I fall down those stairs, that's with a bioprosthetic valve, that's a lot less tricky. You can stop my Coumadin for a couple of days. I'll take baby aspirin, go fix my hip or fix my knee. And let's be honest, we want these people to live into their 80s. It's a tough decade. And so I really believe that, again, we default and we say, well, you're on Coumadin anyway. I don't know. I think the medical management of the patient changes, and I am absolutely unconvinced that if you're 75, your chances of a reoperation are less with a mechanical valve than a bioprosthetic valve. It should be incredibly low for everybody. So I realize we push the envelopes, but I think it's what the patients want. And I just don't see that. I don't know why we all think if we're making a decision tomorrow that, and we're talking about developed countries that have, we'll talk about undeveloped countries too, but in developed countries, if you're getting a prosthesis 15 years from now in Canada, it should be possible to find a center that will do a great reoperation and replace my valve again. And if the valve-in-valve data gets somewhere, that would be even better for certain patients. But I think it's going to be a while. And remember what I told you, this is always a dichotomy of the heart team. Put the biggest valve in you can so the patient is a candidate for valve-in-valve. Okay, I will. All the patients that get replacement are either ischemic or rheumatic or MAC and old people. They don't have big orifices to put them in. It's not like you can enlarge the mitral orifice and oversize the valve very much. At least do it safely.
So anything that can be done technically to plan for the second stage, the valve in a valve? Or you would just address that?
I'll let Marc answer that.
Marc.
Do you ever take chances in the first operation for this hypothetical la-la land of valve-in-valve one day?
Really short answer, no. I put in the best, largest prosthesis I can, but as you said, there's no real mitral angular enlargement procedure short of a commando, which would be a crazy thing to do for this. So no, and the second operation, our data is the same as yours. The safety is the same as the first operation. It's not a big deal.
And I really mean it when I say that like today, the whole day, much of it is about complex aortic surgery. And no one's going to watch this and think, I could never do that. Should never try and reimplant a valve. It's so complicated. I don't want to be on call and see a dissection. I'll have to do an emergency bend tall. You guys would never think that. But somehow once it says the word mitral and it's a re-op, oh, that's going to be a high-risk procedure. It's actually a very low-risk procedure. Anyone in this room that could do any of the aortic operations we're talking about today can do a mitral valve replacement with the same safety as the first operation if you follow the rules, which is the preoperative assessment. And if they have pulmonary hypertension because they had severe TR, because they let the valve ruptured and they got heart failure for a month and we tried to not operate on them, bring them in the hospital for a week. Optimize them. You know, you have to plan, and there's a lot of homework preoperatively to do safe mitral valve replacement too, because sometimes those patients present and they're fairly sick. But I'm convinced, Mark, and I think it's not that you went to Cleveland or Sinai, and that's why you got a safe operation. We can all do a safe mitral valve replacement, but you've got to put a little more effort in some of the patients to have them have the same risk as a first-time operation.
Well, I think we're going to conclude that first part of the day. Thank you very much. I think it was a very important